In this video essay, I will be critically examining the DSM-5 disorder category of Generalized Anxiety Disorder and determining if the nature of the disorder, as described by the DSM, actually constitutes a mental illness. One of the reasons I'm investigating this disorder is that I find it relevant to people in college or people my age who seem to be expressing a lot of worries not only about their current lives, such as their activities, interests, relationships, but worries about the future. Given that universities prioritize finding a successful career for its students, the idea that students develop chronic worries in response to this expectation seems to be a necessary reality to investigate. Determining the nature of generalized anxiety disorder, then, is a relevant task given the current social climate many of my peers find themselves in. I ultimately argue, however, that this DSM disorder needs to be revised to reflect more of a genuine illness because, as it currently stands, the way the disorder is characterized reflects more of a problem in living than a genuine illness, which I will get into later. Now, there are 6 general diagnostic criteria associated with generalized anxiety disorder. The first criterion stipulates excessive anxiety and worry occurring more days than not for at least 6 months about a number of activities or events. The second criterion simply details, the individual finds it difficult to control the worry. The third criterion explains symptoms associated with the anxiety and worry. The fourth criterion states that these symptoms cause clinically significant distress or impairment in important areas of functioning. The fifth criterion states that the disturbance should not be attributed to the physiological effects of a substance or medical condition. The sixth criterion says the condition can't be explained by another disorder. I would say that the final 3 criteria require the most clinical expertise to identify, as a more trained clinician would need to determine 1, what constitutes significant impairment of functioning, 2, what constitutes the physiological effects of a substance or medical condition, and 3, the clinician would certainly need to know the basis of other mental disorders that could potentially explain the disturbance. The diagnosis of GAD may indicate a Cummins dysfunction, which means that the dysfunction is interest relative, where the dysfunction of a component is always relative to a given analysis of a system that comprises the component. It is a normative conception of dysfunction, where the GAD's categories emphasis on the symptoms causing impairment in social, occupational, or other important areas of functioning seems to imply that the malfunction is considered problematic in the context of normal social life. It doesn't seem clear that the dysfunction is seen as etiological based on the inability of the mental mechanism to function naturally based on evolution, or a propensity dysfunction based on the mechanism's inability to help contribute to future selective success. The dysfunction occurs in a way that does not serve our occupational or social interests. The problem with the criteria for this disorder, among many other disorders in the DSM, is that it largely determines mental illness based on symptoms and doesn't consider the genetic or biological history or the causes for the disorder. As explained by GAMI, the biopsychosocial model in most cases seems to justify older psychological habits, concentration on current mental status, psychological development, and childhood history, at the expense of progress in understanding the biological aspects of these conditions, careful pharmacological treatment history, development of mood or psychotic episodes, accurate genetic history, and this is from page 10. To clarify quickly what the biopsychosocial model is, it refers to diagnostic psychiatry. Diagnostic psychiatry is a psychiatric model that involves the proliferation of disease categories resulting from the need to combine the intellectual needs of physicians and the economic necessity of insurance carriers requiring a specific diagnosis for billing purposes. This occurred in an attempt to align diagnostic psychiatry with the medical insurance landscape during the latter half of the 20th century. And this is from page 82 of Horwitz. Nowhere in the current criteria for GAD can we find explanations or causes for the disorder, such as whether this condition manifested in previous generations or how the person's biological or treatment history would indicate the probability of this clinical disorder manifesting. Though the DSM properly indicates disorder based on symptoms, this is a necessary but not sufficient condition for determining disorder. A number of questions should be asked about the causes of the anxiety. If someone shows signs of constant restlessness, being easily fatigued, has muscle tensions, can't sleep, as stated in Criterion C, is there an explanation for this that can be rooted in detailed genetic history or the person's psychological foundation? Not only does the GAD exclude the involvement of childhood history in the disturbance, which could easily be a contributing factor, it fails to even account for the full background of the person in question. The DSM fails to account for potential living situations that contribute to the mental problem, which may render the condition a result of a problem in living rather than a genetic abnormality. A problem in living can be most generally thought of as a factor that exists in society or a person's social life that contributes to psychological distress. Unlike an illness, this does not locate the problem within the patient himself. As explained by Wakefield, this is different from a disorder. Grieving a lost spouse involves considerable suffering, and being in a bad marriage is a problem in living, but neither is a disorder. And this is from page 374. We can apply this understanding of a problem in living to determine what causes GAD, focusing specifically on the first criterion, given that the worry or anxiety stems from activities that one performs, such as school, work, or a variety of aspects of one's social life. This would seem that the causes of distress are largely a result of one's engagement in personal life. The stress that can arise from this activity is no doubt an indicator of the problem of the lifestyle. But is this enough to truly categorize someone as mentally ill when changing the way people go about their activities could prevent these disturbances from occurring? It also seems that the amount of time required to be considered disordered is arbitrary. For example, a person could be diagnosed as having general anxiety disorder if exhibiting anxiety and worry for more days than not for a period of time more than 6 months, but this still does not consider the potential influence of the environment on this condition. Someone could be distressed for a period of only 7 months. Consider the situation college students find themselves in over the course of the school year, and be diagnosed with the disorder when, once again, the criteria fail to account for the living situation of the individual. Many of the symptoms that are part of Criterion C also fail to account for their etiology. Sleep disturbance, irritability, difficulty concentrating, or mind going blank could be signs of a mental illness, but could also be signs of a troubled living pattern, such as the environment in which one lives causing stress. An analysis of the social causes of distress may also play a role in the development of generalized anxiety disorder. Alan Horwitz, in Chapter 7 of his book, Creating Mental Illness, describes how a variety of social factors can lead to mental health consequences. Noting a number of sociological studies which correlate the amount of stressful events a person undergoes with the levels of distress, Horwitz claims that these factors, such as divorce, unemployment, physical illness, and the death of close relations, are critical causes of disturbances. Further factors, which could be more limited in scope and not apply to a majority of people, but nonetheless are important for mentioning, can include combat experiences, criminal victimization, or severe abuse as a child. Problems that Horwitz mentions that I believe are most relevant in the discussion of GAD are mentioned on page 160. When population samples are asked about their perceptions of the major causes of nervous breakdowns, the 4 most common responses are stress, problems of others in the social network, work and school problems, and financial problems. Because GAD aligns strongly with these conditions, it would be meaningful to describe the condition as a result of external social factors. Correcting this disorder would mean changing the nature of social activities causing the problem, but this would not give reason to stipulate the problem as an inherent and uncontrollable disorder. As a result, a transformation of this DSM category would better position GAD as a mental illness by clarifying if the disorder has an etiology leading to its manifestation. I don't believe getting rid of the DSM category of generalized anxiety disorder is a necessary task, because there could be cases where uncontrolled anxiety and worry do result from causes other than social activities. And in this case, the condition would be considered a genuine mental illness. To modify the current DSM description of generalized anxiety disorder, I recommend adding a criterion that clearly stipulates the condition can't be solely attributable to participation in social events and activities. Further, I argue that there should be a criterion explaining that the condition is a result of a dysfunction of a mental mechanism that does not align with its purposes in evolution. To be specific, the GAD should demarcate that the anxiety is dysfunctional at a level that cannot be evolutionarily justified. An example of this anxiety involves a severe incapability of overcoming this condition because it can't aid in survival and reproduction. The condition would have to be viewed as troubled in the sense that it represents a problem that can't be explained by natural selection. Wakefield's theory of mental illness may be of use here. GAD would be a mental illness if the anxiety causes harm as judged by culture and the anxiety results from some mental mechanism not performing its natural function, the function being an effect that is part of the evolutionary explanation of the structure of the mental mechanism. The value of incorporating this notion of mental illness within the DSM is that it allows the DSM to clarify that a mental illness has to be in part the result of some mechanism not performing its natural function. The current version of GAD lacks a proper explanation of why the disorder happens. The value criterion seems evident in the current version, but to make sure one has a genuine generalized anxiety disorder, the description should ensure that it is not entirely socially caused, and also the description should ensure that it's the result of a malfunctioning mental mechanism that is oppositional to traditional human procedures responsible for regulating anxiety.